I'm hosting this on behalf of the Cure Parkinson's Trust, the Parkinson's Movement, and finally Journal of Parkinson's Disease, who all together make these webinars that occur every 3 months possible. Today's webinar is focused on what's called prodromal Parkinson's disease, and we have an outstanding group of panelists who are going to discuss questions. We have already had some questions that have been submitted to us by email, and we have them all on our lists and have some ideas about how to discuss them. But we also welcome you, the listeners and watchers of this webinar.
We'll introduce the panelists just shortly, but there is a Q&A panel where you can submit questions to the panelists, and we will also work to a pre-submitted list of questions as well. Daniela, do you want to introduce yourself?
Yes, certainly. My name is Daniela Beck. I'm currently Director and Chair of the Department of Neurology in Kiel, Germany. So I'm in charge of all kinds of neurological diseases, but my personal focus is and has always been Parkinson's disease. So already as a very young resident, I started to work with individuals living with Parkinson's disease, and this has kind of formed my whole medical and scientific life. I've learned a lot from people living with Parkinson's disease, and one of the major aspects I got very, very interested in was that symptoms can occur, and we will talk about that today, even before the diagnosis is made. So this has, after some time doing other kinds of research in Parkinson's disease, been my focus for many, many years, and I'm really glad and feel very privileged to talk with you about it today.
Thank you, Daniela, and we're very lucky to be joined by you as well. Can I introduce Philip Herbert, who's also on the call?
Thank you very much for inviting me today to speak. I'm a retired professor of family medicine at the University of Toronto. My main interest was and still is in medical ethics, in a variety of subjects. And I also have had Parkinson's for 35 years. So I have a particular interest in the prodromal phase of Parkinson's disease. And we'll talk about that today.
Okay, I hope you can hear me again, and I want to thank you, Alastair, for taking over. This may happen several times during our webinar, but let's introduce the final panelist, Aleister Neus. Who are you?
Thank you, Patrik. So my name's Aleister Neus. I'm a consultant neurologist in London, working in general neurology and also movement disorders with a major focus on Parkinson's disease. And like Daniela, my interest in Parkinson's disease started years ago, really, when I was still a medical student, and I got interested in smell loss as an early feature of Parkinson's disease. And so that was about 15 years ago. And my interest really took off from that point. And I've been interested in risk factors and prodromal features and everything about Parkinson's disease since then. So I'm delighted to be joining this call as a panelist or as the question provider if Patrik cuts out again. Thank you.
Thank you, Alastair. So I'm going to give you the first question, which is, what is prodromal Parkinson's disease?
Okay, so prodromal Parkinson's probably means different things to different people, but I guess the best way of describing, or the way that I think of it, is what happens to people prior to the point that they get a diagnosis of Parkinson's. And so it's really the constellation and collection of signs and symptoms that emerge when Parkinson's pathology is starting to accumulate in the brain, up to the point that those signs and symptoms have manifested and a diagnosis can be given. One thing that interests me is whether the phrase prodrome or prodromal describes a singular entity or a range of different entities. And I think there is good evidence to suggest that there are different prodromes to Parkinson's, different routes by which through which people pass on the way to getting a diagnosis of Parkinson's. Just like after diagnosis, there are different types of Parkinson's disease that people experience.
So Daniela, you are a pioneer in this field. Those of you who don't know, Daniela co-chaired a Movement Disorder Society committee that first about 11 years ago, was asked to set up criteria for what the prodrome would be, and she co-chaired with Ronald Postuma. And I also want to take the opportunity to say that the two of them are being awarded the J. Van Andel Award for Outstanding Achievement in Parkinson's Research in about 3 weeks from now. So what a great person to answer the next question, which is how long does this prodrome last? And remember that when I started doing Parkinson's research in the 1980s, prodrome didn't even exist. And the notion that it might be something that you could detect, weeks or months before would have been strange. But I know what your answer is going to be, and it's even stranger than that.
Much, much stranger. Although one needs to say, and that's what I want to like to add to what Alastair has said, it's really inter-individually very different. So the prodromal phase is not a prodromal phase, neither with regard to symptoms, nor with regard to duration. But what we understand nowadays is that it's not months, that it's not years, it can even be decades. And that means that the pathological process, which finally also reaches the substantia nigra, which leads to degeneration of the dopaminergic neurons and the motor symptoms, is also already evident in many other parts of the nervous system, not even only the brain, but also other parts like the peripheral nervous system. And that's why symptoms can occur quite early, because the brain is not affected at that time, and produce or lead to some symptoms. We will talk about these symptoms in a few minutes. They are very, very unspecific often, so people don't realize it's Parkinson's disease. And only when you ask them later on, for example, have you realized constipation or hyposmia before the diagnosis was made? Many say yes, but this had nothing to do with Parkinson's disease because it's already occurred 10 or 15 years ago. But we now know that it can already be a sign of the ongoing pathological process.
So you mentioned constipation and loss of sense of smell, and Alastair also mentioned loss of sense of smell. What are the other symptoms, or should we call them signs? Some very minor signs, perhaps. What are they?
Well, anything which is connected with our nervous system can be affected. So, of course, when we look at the autonomous nervous system, where when we talk about constipation, we address that, but also urinary dysfunction is very frequent, erectile dysfunction is very frequent. So these are all signs that the autonomous nervous system is affected by the pathological process, which is the reason for the later development of motor symptoms. Then all sensory systems can be affected, like hyposmia. Also vision can be affected. So we have different signs on that side. Many, many different aspects of our mental or psychical system can be affected. For example, depression can occur early, many years before we have motor symptoms, or we realize motor symptoms. Slight cognitive signs can occur prior to the motor symptoms. So we have a wide range, often very unspecific, but when they accumulate, of course, we see that the nervous system does have a problem. There are some symptoms which are more specific, and one of the symptom with the highest specificity is REM sleep behavior disorder. This is a disorder which has a likelihood to later on lead to motor symptoms of Parkinson's disease of 70 or 80%. We say nowadays, at least in 10 or 12 years after the symptoms are realized. And it's characterized by an acting out of dreams, of nightmares during the night. So normally when we sleep with loose muscle tone, because this is just what's happening when we are in our REM phase, and REM phase is the phase where we are usually dreaming. REM is a shortage for rapid eye movement. So everything is, the whole muscle tone is loose, but our eyes are moving very quickly on our lid. So this is the REM phase. We are sleeping, we are dreaming with loose muscle tone. But when we have a REM sleep behavior disorder, the muscle tone is not loose. So we can act out dreams. And as these are often nightmares, people can really act out their dreams very vividly. They can hurt themselves, they can hurt their bed partner. So it can be quite dangerous. And this kind of symptom can occur years, sometimes even decades, but often it's rather years before the diagnosis of motor PD is made. And it's very specific for PD or disorders which are very similar to PD, like Lewy body disease.
Actually, we have a question here from Paulette Myers, which is, I have REM sleep behavior disorder. My grandmother and father both had Parkinson's. Is there anything I can do now to slow progression of the disease? I'm 66 years old. And I don't think we should answer it quite yet, but I promise, Paulette, that we'll come to this question. You know, what are lifestyle changes that people today could try out if they believe, or if their doctor believes, to have prodromal Parkinson's? But I'd like Alastair to take the next question, which came from Rennie Winters-Evans. It says, do you foresee prodromal Parkinson's becoming recognized as the real first stage of Parkinson's? And there's some little sentence in between, but I think the key here is, when will this be validated in the neurology community as the actual earliest stage of the disease, so people can take action earlier? Otherwise, it's like making someone a pre-cancer person wait until it becomes cancer. So that's a very good point. So what do you think about this, Alastair? When will we get rid of the prodromal label and just call it Parkinson's?
So I think this is a very challenging question, actually, to answer succinctly. I think one needs to be quite careful when trying to relabel something as a disease currently in the absence of any kind of demonstrable disease-modifying drug or clear neuroprotective strategy that one can use. So I think that the current notion of prodromal Parkinson's or being in the early stages is probably mainly exists in the research space, but has the potential to move to a clinical setting where an individual or an individual person would like to find out more about whether they're in the prodrome or the at-risk stage. But applying that at a general population level and moving the point of diagnosis forward without anything that can be done from an intervention point of view, I think is quite a dangerous place to be. And I don't think we should do that, because I think at the moment it leaves us open to quackery and kind of false claims about things that can be done. And still a lot needs to be done in the research setting.
So that is actually something I'd then like to ask Philip about, because you come from medical ethics and you yourself, as you said, have been affected by Parkinson's, well, for at least 35 years. You were diagnosed 35 years ago. How do you view what Alastair just said, that there's a danger of using the label Parkinson's when it is today prodromal, but in the future it might be already called early Parkinson's, in the absence of any therapies that it can actually slow or arrest progression? I think you're muted, Philip, so you have to unmute yourself.
Sorry about that. Yeah, I think that there are many issues concerned with this. I think there are negative medical and psychiatric side effects from making a premature diagnosis. Now, and a lot of uncertainty obviously attends to how readily this diagnosis will be made. People may make changes in their life. They may make uncertain about the future. They may make plans they wouldn't have made otherwise. And many, I think it's already been said, many patients are skeptical that making this move to a stronger diagnosis will make any difference in terms of therapy. So I think and the other problem, of course, is stigma, the labeling and so on that goes along with the diagnosis of Parkinson's. Has implications of driving, insurability, and so on. So there are a number of implications of it that are quite serious. On the other hand, there is this gulf between what we can do for patients symptomatically with Parkinson's, which is a wonderful thing we can do nowadays, and I wouldn't be speaking today if I didn't have benefit of those interventions. And but there's a great gulf between that and the preventative medications preventative interventions that can be used to prevent the occurrence of the full-blown Parkinson's disease.
There is a comment on this actually from the person who asked the question before, Rennie Winter-Evans. She says that why don't we tell people that they're going to get Parkinson's, essentially, and then try things such as intense exercise, anti-inflammatory nutrition. These are presumably measures that are harmless. Intense exercise, unless you do downhill skiing in powder, is probably okay. So why wouldn't one suggest that? Although it's not absolutely scientifically proven to slow progression, it's only a hint. Do you think ethically it's a bad idea to say to people, well, you have a 90% risk of getting a neurodegenerative disease, go out, exercise, change your diet so it's as little sugar as possible, as healthy as possible?
Yeah, I don't think there's anything wrong with giving that advice generally to anybody with any kind of illness, whether it's particularly specific for Parkinson's, another matter. And I think, you know, most people, in fact, the studies have been done show many people don't want to know the diagnosis if they're not sure of it. You know, and if you can't do anything, nothing can be done to prevent it anyway. So I think the danger is people will look to untested therapies for the disease, and many people won't turn out to have Parkinson's disease in the final instance. So it's a difficult balance that has to be made there.
May I comment on that, Patrik?
Please, yes, please do, Daniela.
I think this is an enormously important issue we're currently discussing. The first point is, and Alastair has very nicely commented on that, is prodromal Parkinson's disease? And some of the scientists would say yes. REM sleep behavior disorder, especially if you have other symptoms going along with it, like constipation and hyposmia and whatsoever, is Parkinson's disease. I think one needs to be kind of flexible already nowadays, because it will change in the future. I'm pretty sure after I've been working in that field for several years, it will change. The thing we now need is preclinical markers, meaning not only symptoms, but also signs that the symptoms we see are symptoms of Parkinson's disease, because constipation, urinary dysfunction, hyposmia can occur because of other reasons.
So give us a couple of examples of such things you could do, like brain scans or measure the clumped protein. Tell us about those.
So that's the important thing. Nowadays, we diagnose Parkinson's disease because people have specific motor symptoms. But we can, for example, look into the brain with a DUT scan. This is a nuclear medicine method where we see how the dopaminergic neurons are functioning in the substantia nigra and how the dopamine is released and then gets into other parts of the brain. We can take a picture of that and we can see what it's reduced. So imagine you have an individual with REM sleep behavior disorders, no motor symptoms yet, but a reduced uptake of the tracer in such a DUT scan, in such a nuclear medicine method. This is already Parkinson's disease, one needs to say, because we only need to wait until these people get their motor symptoms. The problem is that we don't know the time frame. So we don't really know whether this person during his lifetime will really develop those motor symptoms. A therapy with side effects can't be given to this person, but still there is this likelihood, and this is why it's extremely important to give some suggestions, some advices to those people who already know that there's something happening in them. And of course, there's also a suffering of the non-motor symptoms which needs to address. It's not only that we care for motor symptoms, but if somebody is constipated, has urinary dysfunction, has REM sleep behavior disorders and depression, you need to treat all those symptoms and you need to talk to those people with those symptoms. And that's why I think it's extremely important that there are clinicians, that there are centers which care for those people nowadays, because people are informed, they look into the internet, read about it, and they know it can be a prodromal symptoms. It can lead to Parkinson's disease. And even it's not 100%, there is a high likelihood for me. And I want to get the best advice possible what to do in my life. That's at least what many people want. And one important aspect is, and that's bringing me to what you've said, Philip, I think we need to find out who wants to know what to do. And we also have to accept that there's a right not to know. that there are individuals who just don't want to know. So if somebody comes to a doctor with symptoms of REM sleep behavior disorder and his wife has been hidden several times during the night, then we can tell him that it's REM sleep behavior disorder and we can give him medication for that. But if we realize this person does not want to know anything about any probability of any other kind of disorder, we don't have to tell them. So we need to find out, to figure out whether they want to know or not to know. But this is another subject.
Yes, but I'd like you to tie into this. Maybe Alastair could fill in. You did a study on this, right? You did a questionnaire where you asked people, would you want to know and what circumstances? So what was the outcome of this?
Yeah, that was very interesting. We did it retrospectively. Would you have liked to know? So patients who already lived with Parkinson's disease for several years, who now know what it's like to have Parkinson's disease, would you have liked to know beforehand? And the majority, more than 50%, would not have liked to know, even if they would have had symptoms. That changed when they got the possibility to answer, if you could have done anything which changed your lifestyle, for example, physical activity, nutrition or whatsoever, if there was anything you could have done to change the probability of getting it at that specific stage, maybe to delay it somehow, to not get it that severely or whatsoever, to change the course of the disease, would you have liked to know? And the majority, more than 80%, would have liked to know. So it's definitely the issue of being able to do something oneself, not being helplessly just sitting there, not being able to do anything. This is the major point for the patients we saw. But of course, for that, we need to talk to people and need to understand where they are, what they want to know.
Can I come in there and just make a comment? Because I think the interesting thing for me about that paper was as you said, I mean, obviously it was your work, and over 50% said that they would not have wanted to know if there was nothing that could be done. But it was a bit like the Brexit vote in that it was only very narrow, and there was about 46% of people that would have wanted to know. And so it really comes back to the comment that Philip and Daniela have already made. This is very much an individual level decision. And I think it's come up in the chat comments as well about whether we should be considering screening for Parkinson's disease in its prodromal form, doing similar things to cancer screening. I think there are two major reasons why we can't do that right now. I would argue that we don't know enough, and I think Danielle has already touched on this. We do not know about sufficiently about the natural history of the various PD prodromes that there are. And the second thing for a screening criteria is that you have to have something proven that can be done about it at the early stage. And I accept that exercise and a generally brain healthy lifestyle are important things to commit to anyway. But until we show that they have a demonstrable impact on reducing the progression of that prodromal phase through to a current clinical diagnosis of PD, I don't think we can start to talk about screening. And so we're left with working at the kind of individual level where we need to explore with people whether or not they want to know about things.
In the beginning, and studying the loss of sense of smell. Of course, screening with loss of sense of smell would be complete nonsense because there are so many reasons for loss of sense of smell and so many people that lose their sense of smell that it wouldn't be a good instrument. But what would you predict in the future would be a good instrument, and perhaps a combination of instruments to identify people with a very, very, very high risk of becoming diagnosed with Parkinson's?
Well, I think we've mentioned RBD already as probably the strongest individual prodromal feature, whereby we have probably the best natural history evidence to suggest what will happen over time. The problem with RBD is that it's rare in the general population. There's a couple of studies from Asia which show that the prevalence is about 1%, and in order to diagnose it, you'd need an overnight sleep study. So that's not going to be the source of most of our patients for kind of.
Could I just interject, Alastair? So 1% of the general population has RBD if you do a proper sleep study. What proportion of people with Parkinson's disease have a history of RBD? Ballpark number.
Well, I think you will hear different people say different things, but my clinical experience and the literature that I believe it's in the region of 30 to 50%, I think.
Mm-hmm. And for hyposmia, it's even higher, right? If you look at the history of hyposmia.
So you mentioned that smell loss is non-specific, and I would agree with that, but up to 90% of people with Parkinson's will experience smell loss during the course of their disease, and at least 2/3 of those will have smell loss at the point of diagnosis. The difficulty with smell loss is people are very poor at recognizing when they have lost their sense of smell. So you really do have to test this objectively. And something that we've not mentioned, but I'm very interested in, and I think it's very important, is the emergence of subtle motor dysfunction prior to diagnosis, which I also believe goes back a long way into the prodrome. You know, the diagnostic features that we currently make a diagnosis on, bradykinesia, rigidity, and tremor, they don't emerge overnight. They go back many, many years alongside many of the non-motor features. And if we could get a better handle on objectively measuring those, then I think we could be more certain the combination of motor features and RBD, the combination of motor features and idiopathic anosmia, I think those things in combination would be really, really telling.
There's a question from somebody called Frank Mondo saying, what are the most popular prodromal symptoms, numbers 1 to 5? And I think popular, in this case, it means what are the most sensitive and most specific, and the answers will be slightly different there. But so what do Alastair and Daniela think? We've mentioned loss of sense of smell, REM sleep behavior disorder, constipation, depression. How would you rank these in terms of being strong signs that there will be life, and how specific are they for the disease? And it's a tricky question to answer in 2 sentences, an overview.
You were a bit frozen, Patrik, but from what I understand is that concerning sensitivity and specificity now, and we already mentioned that RBD, REM sleep behavior disorder, is quite specific. It's not very sensitive because not everybody who is in this prodromal or suspected prodromal phase has REM sleep behavior disorder. And in fact, none of those symptoms occurs in everybody. There are individuals who show up with motor symptoms who have neither hyposmia, nor constipation, nor depression, nor REM sleep behavior disorder. I think we need to keep that in mind. So again, and that makes the whole story complex, it's an individual disease in the prodromal phase and in the clinical phase. But still, when it goes back to the specificity, and that's how we develop the criteria, we understand that if a symptom occurs, for example, REM sleep behavior disorder or constipation, and we follow those individuals longitudinally, we see that a certain percentage develops Parkinson's disease. It's the highest percentage is in REM sleep behavior disorder, and that's then followed by hyposmia, constipation, urinary dysfunction. But there's quite a gap between those, and that's why it's important what Alastair mentioned, that we kind of add different symptoms which may occur, and that we really, as medical people, ask individuals, have you also realized whatever? So we get an understanding of that there's something going on. And what we need, and I've talked already about DUT scan, are other markers which show us that the disease is in progress. So we talked about the brain. There are now new imaging methods being developed, which also show that the heart can be affected, the autonomous nervous system of the heart, or even of the gut. Then there's a lot of research going on with biopsies, like skin biopsies or colon biopsies, where scientists want to see whether the pathological hallmark of Parkinson's disease, which is a misfolding of alpha-synuclein, a specific protein, can already be seen in the skin or in the colon. And there are there's lots of evidence that this is the case in Parkinson's disease, but also in the prodromal phase. And this is why I think this is really a changing time now. Today, we still talk about prodromal Parkinson's disease, but once we have an individual with several symptoms in whom we can then say with great certainty, or we see misfolded alpha-synuclein somewhere in the skin, in the nervous system, or wheresoever, then we are very, very close to what we call Parkinson's disease. And then if we understand how the disease progresses through the nervous system, we want to stop it, even if the brain is not reached in a way that motor symptoms occur. I think this is the aim of all of the scientists who work in the field. We don't want to see motor symptoms develop. We want to stop it beforehand. And that's why we care so much about this population. Of course, we want to alleviate the symptoms, no issue, but we really want to stop progression in that phase.
And Jesse Caveney asked a question which says, how many years until we'll have something proven enough for the clinic? Alastair, do you think that we will know in 10 years from now with a 99% certainty for a large proportion of the people who get Parkinson's, we'll know 5 years before that they were going to get it, or whatever we're going to call it? I could add that I know that Daniela Berg and Ron Postma, you wrote a review for Journal Parkinson's Disease where we asked you to look into the future and predict where will we be in 2040, I think. And you said in 2040, the term prodromal will no longer exist because it is going to be called Parkinson's. So Alastair, do you agree with that timeline? 2040, we'll have a different type of criteria, or will this happen much earlier? Or?
No, I think that's reasonable. I think I want to clarify my earlier comment, which is not that I'm resistant to moving the point of diagnosis forward. I think that is important, but it needs to be done in the right way and in a very careful way to avoid to avoid adverse outcomes from that. And, you know, there's a lot of, at least in the UK, there's a lot of people advertising dementia prevention services and things like that, making a lot of money off people that are feeling vulnerable in the early stages of these conditions. And that's what I absolutely wouldn't advocate. So it has to take place in a research setting and then transition from research to the clinical setting in the right hands and within the right ethical and an individual level framework. In terms of therapies, I think that my personal feeling is I think you've got two main approaches to identify groups that have a single homogeneous risk factor and to go after a therapeutic or an intervention in them. So, for example, a group of people with REM sleep behavior disorder, which we know portends to alpha-synucleinopathy. So a synuclein busting drug in REM sleep behavior disorder. For people that carry GBA mutations, a drug that's targeted at GBA, and for LRRK2, something that works via LRRK2. And then you've got the general population approach, which we try to take with Predict PD, in which the MDS criteria are also aimed at identifying a high risk group of people, or a group of people that are in the PD program. And for those groups, I think a more general approach could be taken. So intensive exercise, education programs, social integration, management of weight, and some therapeutics that are low toxicity but may attack or target common mechanisms like mitochondrial dysfunction, like neuroinflammation, and things like that. So that would be my kind of overall comments.
So I'm a little bit curious why you mentioned management of weight.
Well, it's a personal hobby of mine, but not management of my weight, but kind of the relationship that weight and body mass index has in neurodegenerative diseases. And some of the work that we've done suggests that people who are underweight may be at higher risk of getting certain neurodegenerative diseases, one being Parkinson's disease. So, we're always told that we live in an obese society and it's important to lose weight. Sometimes when it comes to neurodegenerative diseases, it may be better to be in the middle rather than too slender.
And how do you merge that with the fact that people with type 2 diabetes and early onset have a higher risk of getting Parkinson's? So there's an association, I should say. We don't know what the cause and effect.
I think I've also done a lot on the epidemiological links between type 2 diabetes and Parkinson's disease from a risk perspective. I actually think there's a curious interaction there, where it may be that type 2 diabetes is a risk factor both for PD, for the occurrence of PD or PD initiation and PD progression. but it's the opposite effect with body mass index. And there was a recent study from Korea, a large cohort study showing that actually the highest incidence of Parkinson's disease occurs in people that are underweight that also have type 2 diabetes. So there's something curious going on there, which is why I think some of the studies looking at metabolic syndrome, where obesity and type 2 diabetes and other vascular risk factors are kind of grouped together, don't show such clear effects. I think you need to tease some of these apart.
So I'd like to switch gears a little bit. And Philip, I'd like to bring you in here because we've heard both Alastair and Daniela have mentioned ethics several times in what they say. You know, this is a complicated ethical question. Letting people know they're a high risk of getting disease. Some want to know, especially if there was a therapy. I think Daniela said 80% would have wanted to know if they could take this therapy. But let me ask you another question from medical ethics standpoint. How important do you think it is to study prodromal disease as a possible inroad to developing therapies in the future that will slow even manifest disease? So somebody who's had Parkinson motor symptoms for 5 years could potentially benefit from a therapy that emerges from studying prodromal disease. And how do you look at that ethically? Isn't it important then to actually study prodromal disease?
I think it's incredibly important. I think more and more diseases we're recognizing have this long lead-in period, that they aren't identified as clinical syndromes, but we know that there are high rate of conversion to those clinical syndromes. So whether it's Parkinson's or cardiovascular disease or other neurodegenerative diseases, Alzheimer's or Huntington's, we all know they have prodromal periods. So you have to make a stipulation, a decision about when you're going to call a particular set of symptoms a condition or not. And I think the worry is, of course, that some people will not want to know that information. I don't think there's a right not to know, actually. I think the right to know depends on the decision being made. It's certainly there's patients can ask not to be informed about something, but if there's important side effects of a medication or other interventions, I think you want to say to a patient who says I don't want to know, well then I don't know that you're ready to take this medication or pursue this intervention. So I think it's very important to make the diagnosis in a timely way, in a way that's consonant with the patient's values and wishes. So you have to know your patients well to know what they want, to know what they're prepared to hear from you. And but I think I think the prodromal studies are incredibly important. And I could have benefited myself from those many years ago, but
can I pick up on something you said there, Philip, and just to ask Daniela a question about her clinical practice? Because certainly in our clinical practice in the UK, I get asked to see patients who have lost their sense of smell or may have REM sleep behavior disorder, and the primary care physician or one of our physician colleagues refers them and says, does this patient now have Parkinson's disease? And at that point in time, they don't fulfill the current diagnostic criteria. So you end up following them up, and that's absolutely fine. But if we're going to take account of patients' wishes, people that may be in the prodromal phase or at risk of Parkinson's disease, I'm not sure that we're getting to see them if we work in a movement disorders clinic. We get to see them when someone else spots it and refers them in. So should we be changing the structure of our clinical practice such that we're seeing like there's memory clinics that pick up mild cognitive impairment? Should we be changing the structure so that we accept referrals from people with a range of different potential prodromal symptoms and then evaluate them from there?
So could I just say, Paul Custo asked that specific question. He says there has to be a big education campaign with general practitioners to identify possible prodromal signs or symptoms, to at least ring a bell in their heads, and then there's a possibility of Parkinson's. And I presume then refer them to somebody who's specialized. Go ahead, Daniela.
No, but it's absolutely correct. Both your the aspect you mentioned, Alastair, as well as the question which has just been posed. The interesting thing about it is that once we have a campaign, there is no possibility not to know anymore. So as long as somebody goes to the GP and the GP tries to figure out, well, does this person want to know or not, and realizes, no, the person does not want to know what's happening in the future, and just doesn't talk with this person about RBD or hyposmia with relation to Parkinson's disease, it's fine. If we have a huge campaign, everybody's of course confronted with that. So this kind of right to know does just not exist anymore. But I agree with you, Philip. This is such a general issue nowadays. Neurodegeneration is so important for so many people that, of course, we all need to understand that if anybody is affected, it's kind of part of the society, and we have somehow to deal with that. So I agree that it would be good to have a very good campaign that people understand that, for example, RBD can be a pre-symptom of motor Parkinson's disease. And I also agree that those individuals should be seen in centers specialized in these questions. And many centers, at least in Germany, already have outpatient clinics for that. And they have cohorts they are following. So if somebody is coming with REM sleep behavior disorder, they have usually lots and lots of questions. And in general, we can't give them the life-changing advice. We can give them some interesting hints what to do. But we keep saying, well, if there's a medication, we let you know. And people really want to come back. So what we allow them, what we make possible in our cohorts is that they come, let's say, once a year or every 6 months. We see then the natural cause, but we also can talk about everything, what's new, how treatment is developing, what's happening in science and so on. And for many, that's really important. They want to be in the center. They want to know what's happening. If there's something which is new, which can be done, then they would like to be involved.
So Daniela, don't you think with the development of mobile technologies, REM sleep behavior disorder will be more easy to diagnose in the home? That you'll send the patient with a little kit and they'll have it for a week, and if they have good Wi-Fi, it will be sent to the hospital and analyzed.
It sounds so easy. There are several groups working on that. Walking also could be so easy to detect walking asymmetries and so many things, but these digital devices, although they are helpful, so far they cannot be applied for that, but there are groups working on that, and maybe in the future it's much easier. The interesting thing is that real REM sleep behavior disorder, really symptomatic one, is often recognized by partners, but people just don't know about REM sleep behavior disorder being a prodromal symptom. So I think this campaign could be really interesting, so that people just read about it and say, oh, really, that's what I'm experiencing, or my bed partner is experiencing. And of course, then there can be other sleep disturbances we need to rule out, but that's something we as medical people should do.
And Joy Milne has asked a question, and some of you may know who Joy is. She has an amazing sense of smell herself, the opposite of hyposmia. And Joy's late husband had Parkinson's, and Joy was the person who realized that one can sense the smell of Parkinson's disease. But Joy's question is actually about minor motor dysfunctions, dropping a screwdriver or dropping darts into his shoe, and not use the teleremote. So is there a future there where this could be used with multiple tiny signs of motor dysfunction? If it were not being able to use the remote control, I think my wife was born with Parkinson's disease. That's just a different matter.
No, but you're right. And I think Alastair has already alluded to that mild motor symptoms, especially all these fine motor movements, can be quite specific. Actually, pegboard is, for example, a test we are using frequently, or also what you're doing in your study, Alastair, with the computer board. So these are things which are very, very helpful. I mean, of course, as you said, in your wife, it could be different, and in other people, it could be different. It's not 100% specific, and people are different, but it's extremely helpful to also include that in such a screening battery, I would like to say.
I would like to ask Joy, who noticed that her husband had Parkinson's disease. Was it him or Joy? Because in my experience, the motor dysfunction, a bit like the smell loss, is something that most patients are less aware of than their spouses or their partners. And that's a curious thing that actually persists throughout Parkinson's disease, the reduced awareness of one's own movement. So people may have some motor dysfunction, but they just put it down to aging, or they're not really concerned about it, but it's actually their partner or their spouse that says, hey, there's something not right here, and that prompts the referral to the doctor.
We will see if Joy can answer via the chat. I've tried to alert her there. There's another interesting question, and maybe this is something for Daniela. There's a question about the negative or positive aspects of the dreams during REM sleep behavior disorder. We often talk about violently acting out dreams. However, somebody said here, it's been interesting that my husband, I think it is my partner, mostly had positive dreams, or mostly has positive dreams, where he's playing sports like golf and tennis. So he swings the things in his sleep. So it is not too many nightmares, which is a good thing. Now, some people might consider playing golf a nightmare, but if you're good at golf, it's not a nightmare.
Well, great for your partner, really great that these are positive dreams. The majority, unfortunately, has negative dreams. The majority really has nightmares. And this is kind of, it's not 100% specific as you realize with your partner, but it's what happens to most of the people, and that's why they don't like it. If you have nice dreams during the night, you don't really care that much, but this is the nightmare character is the thing which is bad, and this is the majority.
And do you have any idea what the biological underpinnings of this are? I guess that's simply not known.
It's not known. I know that there's a group working on that or trying to figure that out, but it's primarily a description what they're doing currently. They try to figure out how many have these kind of dreams and others. And the bad thing about it is that many people don't remember their dreams anyhow very well. So it's really difficult to do science on that.
All right, we have 12 minutes to go, and I think we have to focus a little bit about what can we do in the future in terms of therapies. And we've touched upon this briefly, but what are the most promising approaches in your mind that we could apply already during the prodrome to prevent manifest Parkinson's? And I welcome anybody who wants to start that discussion. And it's important. We've said it's important for the ethics. Diagnosis state will be incredibly important and valuable if we have something that we can do to slow disease progression.
Maybe I can start with just some preliminary words. And these are that when we're talking about therapies, we always need to keep in mind that most of the individuals we will treat are primarily healthy. They may have depression, they may have constipation, but otherwise they're healthy. And when we now look at many of the therapies which are being discussed, we need to consider that some of them may have really severe side effects. So before we talk about anything else, I think we need to be sure that we want to treat or we want to prevent something, but we can't make people sicker than they are because of the treatment we are giving. I think this is extremely important. And that brings us back to whatever we can do with regard to our lifestyle, which is just normally healthy, which can change the course of the disease, is of course the first thing we should recommend. And we really need to work on that and to find out what it does. And we know, and we come back to physical therapy, that individuals who train a lot during their mid-ages, they have a hugely reduced risk of getting Parkinson's disease when they're older. So these things do happen, although we don't have the best numbers now. This is just what we need to know before we talk about therapies. And the other thing we need to know is that, and Alastair has already alluded to that, Parkinson's disease is not Parkinson's disease. So when we want to treat in the prodromal phase, we need to make sure that we are treating the right form of Parkinson's disease. If somebody has a genetic background and a specific genetic form, it's probably much easier because then we know the cause, or at least part of the cause, and we can address the cause. For example, mitochondrial dysfunction or whatsoever. If we don't know the genetic background, if there is no genetic background, neither known to us, nor maybe there exists one, then we need to do something else. For example, on alpha-synuclein. And Alastair, you can, of course, add to that. I don't want to talk too much about it, but what I want to say is there's much to think about before we treat.
I could just add here, sorry.
No, go ahead.
I was going to say, I think that I don't have any brilliant suggestions for what we can do preventative-wise, but I think it's extremely important to, whatever we do, to be accurate in our diagnoses. as accurate as we can be beforehand. Because the worst thing to do is to have false positive patients are falsely diagnosed and end up worrying about that, or they've got 1 or 2 symptoms of the prodrome. Does that mean they're necessarily going to get Parkinson's? No, not necessarily. So I don't think you disclose to everybody, right away when they've got 1 or 2 prodromes that they're going to have Parkinson's disease. We have to be extremely careful around causing more harm by our diagnoses than good, and otherwise it'll leave patients very anxious and worried about needlessly. Not that I think it's our job as physicians to prevent patients from hearing unsettling news. Sometimes the news is bad. You can't ignore that. Sorry,
Could
Alastair.
I want Alastair to come back in, but just interject briefly. Joy Milne has answered that she diagnosed something was wrong with her husband 12 years before he was formally diagnosed. And Paul Custo, whose wife Penny has Parkinson's, he was also aware of movement symptoms well before she was. His one. Go ahead, Alastair, please.
But I want to pick up on 3 points then that we've just said. So one, on Joy's comment there, that what we see from observational studies is that being married is a risk factor for Parkinson's, and I'm sure that's because the spouse notices the motor symptoms of Parkinson's or the non-motor symptoms, and it prompts referral. For Alzheimer's, it's the opposite. Being alone, being not married, not having a partner is a risk factor, and presumably that's because of a loss of social network and social integration. I think Philip just made a really important point. In medicine, we have always tended to practice a kind of paternalistic medicine where we assume that we know what's best for the participants. But from Daniela's research, there's nearly 50% of people that would want to know regardless of what could be done. From customers of 23andMe and other personal genomic services, we know that there is an appetite out there at the individual level to find out more about risk of neurodegenerative disease. And I think one mistake that we make is that we conflate the appetite for knowledge with a need to then jump to a program of screening, and the two are very different, okay? So when we're talking about an individual level appetite for knowledge, we should be prepared to have these discussions with patients and relatives of patients and in the general public. When it comes to screening, that's a totally different thing. And it's a framework through which you systematically try to identify people prior to the point that they would normally be diagnosed, with the purpose of intervening to prevent that. And we're a little way off from that. In terms of the thing that you just tasked me with though, Patrik, which was to talk a little bit more about what could be done there. I think one important thing is this is all about Parkinson's disease, but Parkinson's disease pathology doesn't occur in isolation. And so as we get older, there are lots of changes that take place in the brain. Vascular changes, there's Alzheimer's pathology that accumulates and may or may not present. And there are other proteins that accumulate and dysfunctions that occur. So when it comes to making lifestyle choices, we should be doing things that are generally brain healthy. Okay, we know that smoking is a so-called protective factor for Parkinson's disease, alcohol too, but we would never advocate starting smoking or starting to drink alcohol to excess, because that's just not healthy in general. So not drinking to excess, smoking, managing one's weight, a commitment to lifelong education and exercise and social network and integration, these are all things that are part of a brain healthy lifestyle as we get older.
And adding perhaps diets that are not pro-inflammatory, so
absolutely,
sure.
Absolutely.
So we just have a few minutes to go, but I have a very interesting question, which is, let's assume that there is a therapy that reduces the risk in a predefined group of people of developing Parkinson's disease by 80%. How do you think the insurance companies will view this? How do you think, what bar will regulatory agencies that have to approve the therapy set for it to be something they want us to launch in a large population? And how will the cost of that therapy influence their decisions and their recommendations?
What country are we talking about? What country are we talking about, Patrik?
Yeah, that's a great question. So you're in Canada, you're fine. In the US, it's totally different. And of course, in the UK, also very different. So from an ethics standpoint, give us a Canadian perspective.
Well, I don't think we've got any brilliant solutions to this in Canada. We have drug regulatory agencies which look at individual drugs and see whether they're beneficial or not. We've got hospitals have their own formularies which they adopt they assess new drugs coming out. So I would think it all depends upon, I mean, I hope that this is generally a rational decision. I don't know that it always is a rational decision, though. Maybe made more on the basis of political factors and religious than good reasons. But you know, I think UK, didn't you have the Noyce, facility there, which was evaluating new technology? Wouldn't it be useful?
Yeah, so the National Institute of Clinical Excellence is the governing body for deciding what will be paid for under the NHS, and that has, you know, very strict guidelines about cost effectiveness, so efficacy and then cost effectiveness. So I think the key thing from my perspective here, I'm not going to give you a direct answer to your question, but the key thing from my perspective is that we've spent so long, okay, Daniela and the groups that she works with and us to an extent, trying to find or develop cohorts of people that are at risk or in the prodromal phase. What we really need to do, and I think we're reasonably good at that. There's still some more natural history to be done. But I think what's really important now is that we start to examine the effectiveness and cost effectiveness of interventions in those groups so that we can then go to regulators and say, we think this works and this is how much it's going to cost.
And what we also need, and I think this is extremely important, we haven't talked about that now, is we need progression markers in the prodromal phase. As long as motor symptoms are the endpoint for a study, it will always take too long. We need to have progression markers in the prodromal phase, which can be addressed by whatever kind of therapy which will change. And then we have an outcome for these kind of studies. Currently, we only have conversion to motor PD, but we don't know whether it will ever happen in some individuals.
And that's extremely important when we go back to where we almost started our discussion today with REM sleep behavior disorders. A very high likelihood of getting neurodegenerative disease, but some people live for 15 years before they actually show real signs of Parkinson's or related diseases. 15 years is a long time.
Mm-hmm.
We had a great discussion, I think, and we have more questions than some of them we're going to try to answer on the webpage, and some of them we might email you personally. And anybody wants to see this webinar again, it's available on YouTube. I think tomorrow it'll be on the Cure Parkinson's Trust and Parkinson's Movement. And I want to thank all the people who asked questions. I want to thank you all panelists for giving a great insight into an exciting new area of research, which hopefully will have a great importance in public health in the future. And I want to introduce you to my 12-year-old who's sneaking around here. He's Swedish. But he looks like an American because he's wearing a baseball cap. That's Theo. I have to come downstairs. He says, Mum wants my help with something. So thank you, everybody.
Thank you.
Bye-bye.
Thank you so much. Thank you, everyone.
Thank you.